worry. You may want to keep an eye on the folks around you. I think there's some UT folks that may be choking on that howdy. They may need to be resuscitated. When Nancy asked me on Monday to fill in for her, she only said she had a conflict. She didn't go into any detail about the nature of the conflict. I did get the distinct impression from her, though, that she asked me to do this not because I'm the campus dean here in Round Rock, but because over the time that she and I have worked together, she has come to see that I share her views to a very large extent about what's wrong with American healthcare and medical education. So she was quite confident in asking me to fill in that the message would be substantially the same as that which she would have delivered. I'll just mention in passing that one can say a lot of things about Dr. Dickey, but the thing that I will choose to say is that I just admired her work ethic. As a public servant, I can tell you she worked very long days and worked very hard to try to bring about the changes that she saw as appropriate for the people of Texas. I had the privilege of going to Bolivia with her, and I'll tell you that at 13,000 feet delivering health care to the native Indians there, I was dragging. You get out of breath rolling over in bed. And she just kept charging and charging and charging, and I just do not know where she got that kind of stamina. Now, a very brief disclaimer. As you all realize, A&M is in a period of transition. And it is likely that during this period of transition, the party line, the official positions and policy of the Texas A&M University and Texas A&M system will be modified and revised by our new chancellor and by the leadership that's in place. And they haven't shared all of that with me yet, but I'm going to tell you what I think, and for the most part, it's what Nancy thinks too. But I just don't want to mislead you that the comments I'm going to share are Ed Sherwood's opinions, for better or worse. If folks higher up disagree with me, I'm sure I'll hear from them. We're going to do four things here, and we're going to move pretty quickly. The first thing I'm going to do is to provide a little bit of context to the problem of graduate medical education, because I don't think we understand any problem if we don't understand it in context. The second and third things I'm going to do are run through the slides that Nancy had prepared, and those slides do two things. They give you an overview of what the A&M Health Science Center has been doing around the state, its growth, etc., and especially what it's been doing in the Round Rock area. First, the big picture of the Health Science Center, and then the second half of the slide speaks to GME. We're going to delve into the GME problem in particular. And then I'm going to conclude with my vision for what this campus of the College of Medicine can do to help solve the problems that we will have discussed up to that point. So first of all, GME is, the problem in GME is one of many problems in medical education. We don't have time to go into all of them, but I'm just going to cite a couple of examples so that you will appreciate that even though it's a very serious problem, it is one among other problems. The GME problem relates to the number of physicians we produce and the number that we retain here in Texas to meet the needs of Texans. But another significant problem in medical education is the cost. You all know better than I do that our federal government and our state government are facing lean times, that at the federal level we're borrowing like $1 out of every 3 we spend, and as business people, you know, that's not sustainable. That can't go on forever. And everybody's going to have to do some belt tightening, and medical education, higher education in general, are no exception. The other problem I would cite is the need for major change to the curriculum and how we produce physicians. The way we produce physicians today basically came out of the Flexner Report 100 years ago and has changed precious little, although it is beginning to change now. Something that happened in the past decade is having a profound effect on how we should train doctors, and that is the creation of services like Google and the reduction in price of memory that allows me on this iPhone to carry literally a medical library. Our access to information is better than it's been at any point in history, and we're still forcing medical students to memorize a lot of things they could just look up. On the other hand, the system in which they work is no longer the Lone Ranger where the doctor is king, but a system where a team of people have to work together, and the doctor needs leadership skills and teamwork skills and needs to know how to work effectively with nurses and pharmacists and social workers. And we're not doing as good a job as we could to teach them those system skills while we're busy forcing them to memorize the Krebs citric acid cycle in biochemistry, which you just don't use in daily practice. Okay. Now, all of these problems of medical education are nested inside. They're not out there in a silo by themselves. They exist within the American healthcare system. And if the last presentation didn't convince you, then I'll tell you right now, the system is broken. It is broken. It is now costing 18% of gross domestic product, the highest of any other nation on earth. Last time I looked at it was 12%. We're 6 percentage points more that we're putting into healthcare than any other country, and the outcomes we're getting are around 25th. A lot of countries are doing better, getting more bang for their buck. So the system is broken. Now, to make things even worse, you as employers want healthy workers, because healthy workers are more productive workers. So what does it take to be healthy? There are 5 major inputs to health. The first is genetics. Choose your parents wisely. A second, to list them in no particular order, is environment. Clean air, clean water leads to healthier people, and if you visit places like Bolivia or Haiti, you can see the consequences of polluted environments. The third, and this is a very big driver, is socioeconomic status and education. Poverty is incompatible with health. Jobs raise the level of health for the population. The fourth is healthcare, or I should say medical care, because our healthcare system is really a sick care system for the most part. And unfortunately, even though we're spending a lot of money on it, it's probably about 10% in terms of the determinants of health. The fifth, which is probably half of it, is personal responsibility. How you choose to live your life. So, we've got a 10% contributor to the health of the population that's costing us a bundle, and it's broken. It needs transformation, and we in education have to train doctors to be ready for the workforce of the future, which hasn't been designed yet. Context. If I can operate this clicker, we're going to go to some slides. Okay, the Texas A&M Health Science Center, under the leadership of Dr. Dickey over the past 11 years, has kind of metastasized to most of the eastern half of the state of Texas. We have locations from Dallas down to McAllen, and I won't read the slides to you, but we're not just in Round Rock, we're all over at least half of the state. We've grown. We've grown in student enrollment, we've grown in faculty and staff, and additional growth is projected, as you can see on this slide. A lot of that growth was right here in Round Rock, because back in, let's see the dates there, 2000 and 2011 and 2000, we weren't in Round Rock. We do some things very well. And I could spend a lot of time bragging about the things we do well, but it's my inclination to talk about the problems because that's what we need to do next, so I'm not going to dwell on our achievements. Medicine at the Round Rock campus. Well, we started in 2008. We currently have 71 medical students on the campus, 34 third year and 37 fourth year students. They do their core rotations in the third year of medical school, which are psychiatry, pediatrics, OBGYN, surgery, family medicine, internal medicine, psychiatry. And by the way, thanks to the support of community doctors and the community hospitals, the St. David's system, the Seton system, Scott and White system, Lone Star Circle of Care, and many others too numerous to name, we are doing an excellent job of teaching third and fourth year students. Now, how can I tell you we're doing an excellent job? On the objective measures of the output of this campus, that is standardized examinations and the quality of the residency programs they get into, there is no statistical difference between our campus and Temple. They've been at it for over 3 decades. We've been at it for 5 years. Just wait and see where we are in 3 more decades. The first residency program in this county was started by Dr. Avery. Right over here, it is a preventive medicine residency. We appreciate the work he did to bring that about, and they just finished having the first medical student rotate on that service to learn about preventive medicine. We have a community-based model. 100 years ago, the Flexner Report said medical education needs to move to the university setting because we have these proprietary schools where doctors are training doctors, not necessarily with scientifically based medicine, but just for the profit. They're charging a tuition. It's a sideline business. The quality in American medical education is terrible. We need to move it to the universities. And it has thrived in the universities. And the problem today is in large part a result of yesterday's solution. Because the problem today is in the ivory towers of academia, the training of physicians has become divorced from the real world practice of medicine. And I believe the solution today is to move the training back out into the community with people like Dr. Martin in the back of the room, Chief Medical Officer at St. David's, and we may have other physicians here from some of the other hospitals, so that students can see firsthand the difficulty of taking care of patients and providing excellent care in a fragmented and broken healthcare system, where in this state about 25% of the people don't have health coverage. We have pharmacy students rotating here. I didn't skip nursing, did I? No, it's coming. We have pharmacy students rotating here from the school down in Kingsville. They do clinical rotations in various healthcare facilities, including the major healthcare systems. And we have nursing here. Our nursing programs complement the programs of Austin Community College and Texas State University. The programs we offer are the second Bachelor of Science in Nursing degree. That means really second degree. Their first degree could be a master's in some other field. It doesn't have to be another bachelor's degree. And we also offer a program that takes people with an associate's degree, registered nurses, and brings them on to the bachelor's degree in nursing. That's a primarily online program with testing, for face-to-face for some of the testing. When the state invests in medical education, the community benefits. Now, I'm not going to dwell on this because I've seen all kinds of numbers and multipliers about the economic impact. And as those of you that work with numbers know, it's there's kind of fuzzy math involved in those multiplier factors. But there's no doubt there's a significant economic impact from medical education. College of Medicine expansion. Our College of Medicine was a very small college for its first 3 decades, and it has just recently grown quite a bit, up to 200 students per class, and we have opened up, well, for those of you unfamiliar with the history, for many years, the first 2 years were taught in College Station, the last 2 years were taught in Temple at Scott and White, 2 + 2. And we are still going through the growing pains of a rapid growth and evolution to 4-year campuses in Temple and Bryan College Station, where a student can stay on that one campus for all 4 years, and the opening of clinical campuses the last 2 years in Round Rock and Dallas. U.S. physician shortage, I just want to caution you, the bottom line you can rely upon because that's real data. The top line, physician demand. Well, remember, that's physician demand in a healthcare system that isn't working. If we had a healthcare system that was working, the numbers might not be the same. If you've got a unit within your business that isn't working very well, the wrong solution is to hire more help to do things the wrong way. So, yes, we need more physicians, but those numbers, those projections of how many more we need, and especially what kind of distribution. You will hear that the only specialty that we have enough of in Texas is aerospace medicine. Well, enough, that number comes from comparing us to national averages. Who says that the national average of orthopedic surgeons or heart surgeons per 100,000 population is the right number? And you might say, well, we don't want to be below average. Of course not. But being above average in having specialists, if that's not what you need for the healthcare future, the healthcare system of the future, is not desirable either. Okay, this you can rely upon. This is true. You see Texas in the dark red, and that says that the ratio of overall physicians to population here is among the lowest in the nation. We don't have enough doctors in Texas. And of course, with healthcare reform and expanding access, the shortage of doctors will become a much bigger problem. We are the fastest growing college of medicine in the United States. And in that regard, as we have grown in response to a hue and cry for medical schools to expand enrollment by 30%, and we responded, we have helped to create the GME problem. The GME problem in a nutshell is that as of this point in history, there isn't a spot guaranteed in a residency program in Texas for every graduate of a Texas medical school. We are transitioning into becoming a net exporter of young physicians, new physicians, trained to a significant extent at public expense. And you have to ask, is that good public policy to train them for other states? We are affiliated with medical residency programs in a wide variety of cities. Most of our affiliated programs are up at Scott and White and Temple. We have programs at Darnall Army Hospital. We have programs in Corpus, in Houston. We have our own family medicine program in Bryan College Station, and of course our own preventive medicine program right here. When I say our own, I mean we're the sponsor. Many residency programs are sponsored by hospitals, and they're affiliated with us. We work together to ensure the quality of the education. This slide, the bottom gray is allopathic graduates in the U.S. That's medical graduates, MDs. The next lighter gray is osteopathic graduates, or DOs. And then the top light one is international medical graduates. The country is a net importer of medical graduates. We train many international medical graduates. In Texas, we're at the point of not having enough slots for our own graduates. On a nation, at the level of the nation, as we go forward, we're going to be able to accommodate fewer international medical graduates. Now, it won't happen that they'll just get squeezed out and all of ours will get jobs, because the cream of the crop from other countries often far outperforms the bottom of our classes. We've had an increase in residency positions affiliated with the Health Science Center and Texas A&M. And this slide of the blue is medical school graduates in the state of Texas. The brown is the statewide total of first-year resident positions. The first-year resident positions, of course, are the crucial number, because you can't do the second year until you do the first year. And the green is labeled as the optimal ratio. Well, that is based upon a 1.1 to 1 ratio. Earlier this week, I was at a hearing of the Texas Higher Education Coordinating Board, and there was discussion about this 1.1 number. The consensus amongst the board members and the representatives there from medical schools around the state was that 1.1 to 1 ratio is a minimum ratio. and it probably should be greater than 1.1 to 1, but what's the point of arguing about whether it should be 1.2 or 1.25 when we don't even know how to get to 1.1? Here's the essence of the problem with GME. It's the complexity of the finances. This says it costs about $100,000 per year per resident. You'll find other reports that put that up to $150,000. It's a complicated cost accounting, but it's expensive. The funding sources include Medicare, the VA, Department of Defense, hospital operating budgets. The state makes a small contribution. In short, the funding comes from a lot of different directions. The biggest funding source is Medicare, CMS. This is kind of a busy slide, but let me start with the undergraduate medical education in the upper left. That shows the average cost of training a medical student to be $100,000 per student per year. Note that that's the average across health-related institutions in Texas. A&M is below that, and the average isn't necessarily the optimal, and it's my opinion the cost of medical education needs to go down. We need to become more efficient, more effective, better, faster, quicker, cheaper, all of that. When you look at the GME funding, you see the two blue, the Medicare IME, Medicare DME. That is the bulk of the funding, and would you be surprised if I told you that over time the feds have made that very complicated? So hospitals have to employ a lot of people to count the beans in order to get that money. It is not a simple formula. It's one that you can work with for years and not understand. And down here we have a projection of where the money will have to come from in the future. And this slide shows that it's coming out of hospital operations. And most of the larger systems like Baylor and Dallas and Scott and White and most throughout Texas are paying for residency positions above the cap that they do not get reimbursed for from Medicare. So historically, this funding has been about $9.5 billion in recent years, the DME and IME put together. The direct medical education it's just what it says, resident salaries, things that you can directly tie. The IME, or indirect medical education adjustment, is for the increased cost of care to patients in the setting of medical education. Historically, residents are learning, they may order more tests, the patient may stay in the hospital longer. There are a lot of subtle effects that increase the cost of care, and Medicare has compensated hospitals for them. Unfortunately, the amount of money provided, well, I'll come to that slide. This was all capped back in 1996, and most hospitals are at their cap. There is an opportunity in what are called, and I never heard this term until the meeting earlier this week, GME virgins. A GME virgin is a hospital that has never paid for a resident, and they have a 3-year period to establish their cap. And the way that works, because in 3 years they're going to establish their cap, they better begin with the end in mind and start every residency they ever want, because they're going to establish a cap, and that's all they'll get reimbursed for in the future. As you can see at the bottom, the estimated direct and indirect costs far exceed what is provided by Medicare. And, okay, in Texas, about 15% of positions are funded outside of Medicare. Of course, Medicare doesn't fund any positions in pediatric training. Now, at the federal level, things are bad and likely to get worse, and people have already started to eye that pot of money, and there has been talk about reducing the federal subsidy for graduate medical education. We have a crisis in graduate medical education. The feds are going to help us by making it a bigger crisis. The uncertainty that they might do this has a strong inhibitory effect on hospital CFOs and CEOs when it comes to opportunities to invest in graduate medical education. I mean, it's just like your business. Would you invest in something if the funding source was likely to change in a negative direction in the next few years? The story on state funding is it's a bad news, good news situation. The bad news is it's gone from very little to less. The good news is it was so little to start with, we were able to sustain the less pretty well. At the Texas Higher Education Coordinating Board, there was a sober recognition of the gravity of the GME problem, of the fact that the relatively few dollars the state is able to put into GME, if spread evenly across all graduate medical education, would have little or no impact. So it's more desirable to concentrate those dollars in areas of greatest need for the state of Texas, and I was very pleased that none of the medical schools present argued with the idea that Texans need primary care doctors more than they need specialists. Now, you'll hear there are shortages of everything, but lots of people have trouble getting in and having a regular relationship with a primary care physician. Most of the time when people need an operation, they can find somebody who has the time to do it. So I'm not going to say there's no need for more specialists, but the need is truly great at the primary care level. In fact, if you step back and look at our healthcare system, what's broken and what isn't, people with money travel to the United States from all over the world for our tertiary and quaternary care. It is the best in the world. We are really good at fixing people that need bone marrow transplants and heart transplants and all kinds of high-tech, expensive things. We aren't very good at helping people to stay well and get their diabetes under control and their blood pressure controlled so they don't have the stroke and they never need the rehabilitation. So, we're hoping this next session of the legislature is kind to us, but realistically the state doesn't have the money to fix our problem. They can make it a little less painful. This is another slide that shows declining funding formulas for GME. So how can we avoid this train wreck in GME? How can we avoid producing undergraduates that can't get a residency position? You might say, why does it matter? Well, during residency, people get married, they have kids, they develop relationships, and they have a strong tendency to stay where they finish their training. If they do their medical school and their residency in Texas, about 80% of them will stay in Texas. The numbers are lower. If they do just medical school here, some of them will return. They're Texans at heart. If they do just residency here, many of those will stay. If they do both here, it's about 80%. The real solution to go beyond Band-Aids and to fix the underlying problem, not just the symptoms, the real solution will involve a new way to pay for graduate medical education. Doing it through Medicare. Why should every other insurer be off the hook? Why should Medicare pay for training and all of the other employed patients are making no contribution to the creation of physicians? Doing it through Medicare ties it to hospitals. Healthcare has moved out of hospitals into the community, and the disciplines we need the most, like family medicine, most of that is taught in clinics where the Medicare funding doesn't apply. In my wildest dreams, I see Texas stepping up and coming up with some kind of radical re-engineering of the financing of GME and being a model for the nation. And that might be a hard thing to pull off in our political environment, but maybe it's a little bit easier than pulling it off at the federal level. I don't know. So, GME is a big problem. In the next few years, we will be training doctors that either can't get a job anywhere or can't get a job in Texas. Now, just to be clear, all of our graduates don't want to stay in Texas. They want to go to excellent residencies all over the country, and we want to pick the best and the brightest from other states and bring them in here. So we're talking about a net situation. We're never going to keep every Texas graduate in Texas, but we'd rather be a net importer of physicians than a net exporter. This problem of GME takes place in the larger context of other problems in medical education, that we're still having people memorize things they can look up. The only thing they need to know at the bedside is enough to think of the diagnosis. If I'm seeing a patient in Austin who has compatible symptoms of fever and liver problems and such, and it occurs to me, wow, this patient might have typhus. I've never seen a case, but I heard from public health we've had an outbreak. If the doctor thinks of it, in a moment they can know everything they need to know about typhus. If they don't think of the diagnosis, they're not going to look it up. So we need to change the content of education, and we need to reduce the costs. But the bigger issue is we need to fix the American healthcare system, and most of that fix is going to be a re-engineering of the primary care infrastructure, that one-on-one relationship with a personal physician, and it won't always be a physician. In the future, it's going to be a nurse practitioner, it's going to be a physician's assistant. Many of us feel that the care will be better if they're all working as a team in the same place, rather than folks working independently of physicians, and that'll be a fight in the next session of the legislature. The model I would remind you of is when you go to your dentist. A dental hygienist spends an hour in your mouth cleaning up your teeth and inspecting them. The dentist comes in for 3 or 4 minutes, shakes your hand, asks you how you're doing, but you know the dentist will be there when you need the dentist. The hygienist can clean your teeth better than the dentist could. So it's a matter of having everyone practice up to the full scope of their license and doing it working together on your behalf. Patient-centered medical care. So my vision for this campus of the College of Medicine is, number one, for us to become a full 4-year medical school. Because I want to have the medical school that teaches, that trains the physician leaders of tomorrow, who will not only be good physicians, but they'll be good team leaders, and they'll be good executives, good leaders at every level in our healthcare system to help transform the system into something that better serves the American people. In order to do that, we need to be training them for the full 4 years, because when we get them 2 years after they've gotten into medical school, number one, a lot of time's been wasted, and they've learned a lot of things contrary to what we think they need to know. If we had them for the full 4 years, I would have them start laying hands on patients in their first month, so that they start to feel like doctors and start to think like doctors. And I would have them doing it with nurses and pharmacists. And we're doing some of this interdisciplinary education right here in Round Rock, and the students love it. In fact, just this week, our College of Nursing, with some assistance from the College of Pharmacy, held a disaster drill working with public health. Public health was practicing their ability to vaccinate the whole public in a hurry if they have to in the event of a bioterrorist attack or a pandemic. So they were working with our nursing students and pharmacy students to practice that capability. They used real flu vaccine and they gave it to our medical students. So we are working together already. Okay, so we need the whole 4 years, but let me quickly say, as soon as we have the full 4 years, I'd get to work at trying to reduce it to 3 years. That is a big way to take some of the expense out. Require them to know the basic sciences to a significant extent, learn that stuff in college. When you get to medical school, focus on becoming a doctor and don't waste a lot of time memorizing biochemistry and a lot of stuff that you'll never use. Do it in an interdisciplinary way, have clinical experience from the beginning, and learn leadership skills throughout the whole 4 or 3 years. Leadership skills isn't necessarily stuff like Dr. Dickey has been doing. It can be as simple as chairing a meeting so that the work of the committee gets done within an hour instead of going on for 3 hours and accomplishing nothing. And the physicians that are here will tell you they've sat in a lot of meetings chaired by physicians that went on forever because they didn't know how to run a meeting. The other thing this campus would do is collaborate with the other health-related institutions. We've worked closely with Texas State University and Amarillo Community College. Our College of Nursing is already doing that to try to share expensive resources like buildings and gross anatomy labs. We're past the time when every healthcare institution can afford to have its own and then use it 3 months of the year and have it sitting idle for 9 months of the year. We have to run more like the way you run your businesses, where assets are used all the time, and we squeeze maximum value out of everything that we spend money on. Now, the vision I've just given you, numbers. I would limit our class size to about 64 per class. There are those, there are those that want the class to go to 100 students per class. I'd rather do 64 and do it exceptionally well, training future leaders and excellent physicians. Another reason I'd rather do 64 is there are rumors that another university wants to create a medical school in the neighborhood. And I sat next to Sue Cox from that institution at the Higher Education Coordinating Board. And I will tell you what I told her and what I told the board. Should that come to pass, I will do everything in my power to work closely with them, to collaborate. Earlier this week, we had a big research symposium attended by a Nobel laureate, and we sent an invitation to their faculty. I trained in a city with 2 other medical schools. My medical education was much better because of those other medical schools. Competition belongs on the football field. When we're fighting disease, death, and disability, it isn't about who wins. It's about working together so that we all win. I think I'll just finish there because I think we still have a few minutes, and I'll try to answer your questions. This vision I've given you, I have sold to our dean, who is very supportive of training physicians to fix our healthcare system. I've sold it to our immediate former president, and you can be sure I'll be doing my best to sell it to new leadership as we evolve into part of the Texas A&M University system, because I think it's the right thing. It's what we can do best here at the state capitol, with access to all kinds of healthcare leaders, both in the healthcare systems, in government, in Texas Medical Association, in Texas Hospital Association. We can train future leaders better than they can do it on any other campus. And one final thing, I want to say thank you to the community, to all of you for your support, to the healthcare systems, to the physicians. We couldn't be where we are in 5 short years if it weren't for the community support we've received. And when it comes to my commitment to collaboration, I just want to cite the University Federal Credit Union that has this burnt orange on their business cards. They funded scholarships at our medical school. And you know, that's kind of the spirit of working together for the common good. Are there any questions?
Dr. Sherwood?
Yes, sir.
I understand that we have a very collaborative model here in Round Rock. Would you discuss the differential delta in cost for your students versus other medical schools in the United States or across Texas? I think there's a significant disparity in the way you conduct your business here in the efficiency of it. Could you elaborate on that?
I will try, John. We do train doctors less expensively than many medical schools. Now, to be fair, the cost accounting of what does it cost to train a doctor can get into some fuzzy math, because there are, you know, FASB has accounting practices to assure that financial reports in an industry are comparable, so investors know if they're reading a report from one oil company, they can compare it to a report from another oil company. Well, to the best of my knowledge, FASB hasn't tackled medical education. So the accounting is done differently at every medical school. So you're comparing apples to oranges to grapefruit. One of the things that can make a huge difference is the extent of basic science research you have on a campus. It takes expensive infrastructure to do a lot of bench research that involves animals and things like that. And the costs often get transferred in kind of an internal shell game, and it's hard to figure out exactly what you paid to train a medical student as opposed to support the research enterprise. Now, let me be perfectly clear, I'm not anti-research. In the years after World War II, the federal government poured a lot of money into the NIH, and the medical schools like UT Southwestern that were ready to take advantage of that flow of dollars grew into great research institutions. I don't think those research dollars are going to be flowing the way they did in the past in the next decade. So I think it's incumbent upon us to do mission-based cost accounting and figure out exactly what it does cost us to train a physician, and then start to pare that number down. And the way you pare it down is the same way you reduce costs in your businesses. You look at overhead and you ask, is this essential overhead? You look at the larger pieces and say, can I reduce costs in these big components? There's no magic bullet, but the good news is this is one of the things that A&M can say, quite honestly, we're good at, and we believe we could get better. Yes, ma'am. Well, for your full curriculum. Honestly, I can't give you a precise number in terms of dollars, but I can give you a qualitative answer. It's going to take the collective will of the community. If the folks of Round Rock and the folks of Williamson County see value in a full 4-year medical school that sets out to have a distinctive competence at teaching leadership as well as medicine, to train leaders to fix our healthcare system. If all of you, we've already enjoyed great support from the healthcare systems. With their continued support, with the continued support of the physicians, and if all of you leaning on your elected officials and leaning on my university officials, you know how our democratic process works. It's squeaky wheels that get grease. And there are many communities out there that would like to have what you have here and would like to have campuses built in the future, and they're contacting the A&M leadership all the time. So it's going to take the collective will of the folks here. Now, I don't know what's on John Sharp's mind, but the early signals I've seen from things he's asked and things he's paid attention to, it is my belief at this time that he sees the value of investing in this campus. That's what I believe to be true. If I turn out to be wrong, you'll probably figure it out when you have a different speaker here next year. But I honestly believe that he sees the value of an A&M presence here in Round Rock, and a bigger presence, a bigger footprint. And he's doing everything he can to reduce costs like a good businessman and to promote our brand. I think we're about out of time. One more question? Dr. Martin.
Sherwood, on your theme of leadership and making that part of the education curriculum, is your school or schools nationally with students and residents teaching sort of the whole health of the patient? I mean, we were taught to be zealous about taking care of their health. But the whole health includes their physical health as well, and the cost of medicine. So the concept that it's okay to follow a cookbook, which is based on evidence, to be more efficient in how many tests you order, what the cost of the patient is to the system. Are we starting to teach that to them and make that part of what they learn?
I'm going to repeat a little of that. What Dr. Martin asked was, are we focusing on teaching the bigger picture of the patient's health and well-being in the community, within the family, looking at costs? And the answer is not to the extent we should be doing it, but our curriculum committee is aware of that, and we are migrating in the right direction. And I'm happy to tell you that on Tuesday of this week, we had the inaugural Leadership Grand Rounds presented to our medical students and faculty by Dr. McAfee of Portland, Maine, a former president of the American Medical Association, a gentleman who has devoted his life to narrowing the gap between what we know and how we practice for the benefit of our patients. You know, we had Luc Montagnier here, who got the Nobel Prize for isolating the HIV virus. That's hardcore science, and that's important. But what's even more important today is what Dr. McAfee has been doing, and that is making sure the benefits of our current knowledge are getting disseminated into practice, in team-based practice, for the benefit of all of the patients. And I can tell you, we had a leadership breakfast with Dr. McAfee on Wednesday morning at the Round Rock Health Science Center, and our students were there hanging on his every word. They were soaking it up. They just loved having their daily lessons in medicine and surgery and pediatrics put into the context of taking care of people. He told them stories of how they will become heroes, of how they will save lives. The asthmatic child, the teenager with a ruptured spleen, and his stories, he's a great storyteller. He just had them on the edge of their chairs. So what we're doing right now, Dr. Martin, is we're trying to whet their appetite for the subjects that are not in the formal curriculum, but we know they need to know more about those things. So once we tell them what they need to know more about, the second message is the first step in leadership is to take charge of yourself. Take responsibility for your medical education. Map it out. Use what the faculty give you. Go after the gaps wherever you can find it, but nobody is responsible for your medical education more than you are, and we're going to try to guide you on that path. I think we're done. Thank you very much. You've been an attentive audience, and I've